Hello and Happy New Year. I'm Oliver Mills, Associate Director and Managed Care Lead at Pharmacy Times Continuing Education. So the San Antonio Breast Cancer Symposium, or SABCS, was held last month. And with about 10,000 clinicians and scientists attending from all over the world, this is the largest scientific gathering on breast cancer research. Now, SABCS has come a long way since it started in 1977, where there were about 30 people in attendance. Now there are more than 1,700 original research abstracts presented. So to highlight some of the most impactful data presented, I've invited one of the smartest and hardest working people I know and a regular faculty for PTCE, Dr. Laura Bobolts. So Laura, thank you so much for joining me. Do you mind quickly introducing yourself?
You got it, Oliver. So happy to be here with you today. I am Laura Bobolts. I am the Senior Vice President of Clinical Strategy and Growth for OncoHealth. I am a PharmD and a board-certified oncology pharmacist who specializes in oncology managed care.
Well, Laura, I got to say, you do so many programs for us. You probably don't need an introduction, but thank you again for coming on and talking about some of the, some of the most impactful things that you saw at SABCS. I was wondering if you would mind maybe just going over a couple of the studies or abstracts that you saw that, might be practice changing now or in the future.
So the first study I'd like to review from 2023 San Antonio Breast Cancer Symposium was the NATALEE trial. Now, this was an update from ASCO, where we found the addition of 3 years of adjuvant, which is post-operative, ribociclib added to endocrine therapy led to a 3.1% absolute invasive disease-free survival benefit. Now, this was in your stage 2 to stage 3 hormone receptor positive, HER2 negative early breast cancer patients. Key to this study, it included patients that were high risk lymph node negative, which is very different than what we have with the already FDA approved abemaciclib per the Monarch E clinical trial, FDA approved in patients that are lymph node positive stage 2 to 3 early breast cancer. So in the NATALEE trial, results were reinforced at San Antonio Breast that we found a 25.1% reduced risk in disease reoccurrence. Although unfortunately overall survival data is immature, that always makes it tough for us to make decisions on the managed care side, but in oncology, we have to deal with limited data many times.
Yeah, absolutely. So what is the managed care impact on this? With this information coming up. I mean, abemaciclib's already been approved in this indication. How are we going to be choosing between the two if, if approval does get granted?
You got it. If FDA approval comes, I'm hoping by the second half of 2024, then you will have tough decisions between adjuvant ribociclib or adjuvant abemaciclib. The big difference could come in if the FDA does approve the ribociclib for those high-risk lymph node negative patients, because as I mentioned, currently abemaciclib does not have that FDA indication. It's only in lymph node positive patients. So there you would have a clear answer of which agent to use. Although from a managed care standpoint, it's really challenging because we don't know, is that the subgroup that really benefits most from adjuvant ribociclib? Is it the lymph node negative, or really is it that lymph node positive patient population where abemaciclib could also be used? And I state that because there was a person in the crowd, I believe it was Dr. Cyclops from Rhode Island at San Antonio Breast, who he asked the question, which subgroup benefits most from adjuvant ribociclib? And he further mentioned, because the presenter couldn't really give us a clear answer there because we don't know right now, he mentioned that you would need to treat 50 patients with stage 2 breast cancer at about 3 years of that adjuvant ribociclib, a cost that could be in excess of $500,000 to prevent one invasive disease-free survival event. Now, what does that equate to? A $25 million spend to prevent one invasive disease-free survival event across an entire patient population to prevent one reoccurrence. So from a managed care perspective, that makes it really challenging when you expand a patient population to those that we're not sure are going to benefit most. Now, I am hopeful absolutely in this arena, but it's really hard to tell. And expanding ribociclib to that lymph node negative patient population can expand access to this drug in the adjuvant setting 2 to 3 times that of what we're seeing today for adjuvant abemaciclib. So on the payer side, that can really increase spend.
Yeah, that sounds like it's going to be a challenge. Are you seeing clinicians using ribociclib off-label already?
You know, Oliver, I am not seeing off-label adjuvant ribociclib being used that much today. And I'm surprised because in the managed care world, something gets presented and people want to try it right away. I think there is a little hesitancy here, and also hesitancy because we have very strong data with adjuvant abemaciclib, and that agent is FDA indicated, although in lymph node positive. So I'm not really seeing that today. And in a way, it's a good thing because on the managed care side, adjuvant ribociclib is not typically going to be covered from a broad sense from your payers. And that's because we follow CMS regulations for your Medicare members. Commercial and Medicaid typically follow suit, in which we're looking for something that is either FDA approved, which currently adjuvant ribociclib is not. We're looking to see if it's incorporated in NCCN's compendium. Not yet, even though their guidelines were updated December 5th. As of January this year, it's not in the guidelines for NCCN just yet. And also the NALI trial, it's not published in full text today. So typically we can use scientific literature published in full text in a journal that's eligible per CMS for insurance coverage to extend that insurance authorization. And today we don't have that either with the NALI trial. So broad insurance coverage is unlikely. I'm not seeing people test the waters just yet.
I guess we just need to wait and see what the guidelines say, and it'd be interesting to see how they're both going to be used if the approval, if it does get approved. But more to come, it sounds like. The Inavo 120 trial was, I'm seeing a lot of news about that, and I believe this, this one made quite a splash. Is this on your radar? Is one that could be practice changing, or?
This is absolutely on my radar as a managed care professional. And it was even such a big, impactful study that they squeaked it into the agenda in the San Antonio Breast Cancer Symposium last minute. So you always know that's something to look out for. So within the Inavo 120 clinical trial, this is where they studied investigational inavolisib. Now, this is a PI3K alpha isoform inhibitor. Now, this agent was added to palbociclib and fulvestrant. So you're looking at a 3-drug regimen in patients that had recurrent disease but untreated metastatic breast cancer. And the addition of the inavolisib to palbociclib and fulvestrant, that patient population, led to a 57%. 57%, you don't see numbers like that all the time in breast cancer. 57% reduction in the risk of disease progression or death in that first-line setting of recurrent patients that were, although biomarker selected. So patients had to be PIK3CA mutant, they had to be hormone receptor positive, and HER2 negative metastatic breast cancer.
Well, 57%, that's incredible. So they were biomarkers selected for the study. Currently, where is the PIK3CA mutation? Like, where is the genomic testing being done?
You got it. So I'm more commonly seeing genomic testing being done by next generation sequencing to look for that PIK3CA mutation. Although if we think about the available therapies on the market today, we have alpelisib is FDA indicated with fulvestrant, second line or later metastatic breast cancer, that's PIK3CA mutated, hormone receptor positive, HER2 negative. Whew, mouthful, right? We also have capivasertib that is FDA approved in patients with AKT pathway alterations, which include PIK3CA mutated patients, similar hormone receptor positive, HER2 negative, second line or later metastatic breast cancer in combination with fulvestrant. Now, those are second line. options, right? So sometimes you may see providers doing that next generation sequencing after disease progression on first line therapy for metastatic breast cancer. But now people really need to think to make sure you test for a PIK3C mutation up front before you even start first line systemic therapy once this therapy becomes available, because we know roughly 40% of our patients that are hormone receptor positive HER2 negative metastatic breast cancer could be PIK3CA mutated and could possibly be eligible for this therapy that could really be a game changer in this patient population. Now, we never thought that we could move that needle first line patient population, because your CDK4/6 inhibitors plus endocrine therapy have really changed the game and provided us outstanding results for our cancer patients. But now we see that adding inavolisib, a third agent that tends to have a little less toxicity than a drug like alpelisib, is even more beneficial than that 2-drug regimen. So this is going to be a game changer once this is FDA approved. I'm really hoping for an approval later 2024. I don't know, that's just Laura's speculation and crossing her fingers, because this is a therapy that can really benefit our cancer patients.
It is really great to see this kind of data coming out, for our cancer patients. However, first triplet therapy, first line, that's gotta pose some challenges for managed care.
You got it. So on the managed care side, I really recommend that managed care pharmacists pay attention to this drug, prepare your criteria for coverage ahead of time prior to the approval so you're ready to cover it right away. And to be honest, the results are so astounding on the progression-free survival benefit, and your overall survival data, while immature, is looking very impressive, that this is a therapy that is going to be open to the patient population likely that can benefit most. So those first line recurrent metastatic breast cancer patients that are PIK3CA mutated, hormone receptor positive, HER2 negative. Now, one of the challenges also I think our managed care pharmacists need to keep an eye on is some payers or some PBMs may have a CDK4/6 inhibitor such as palbociclib as non-preferred. And once this 3-drug regimen gets FDA approved, it's going to include palbociclib and fulvestrant in the label, likely with inavolisib. And you would not want to disadvantage patients from receiving an agent like inavolisib because you're not keeping your step therapy or preferred drugs up to date. So this is one where managed care pharmacists need to look out for their policies, their drug strategies, and take a look to see if that palbociclib is non-preferred, because that may need to be revisited once this is FDA approved.
Wow, that's really good insight. And I don't want to keep you on too much longer. I really appreciate it. But any other studies that really caught your attention?
You got it. The HER2 CLIMB-02 trial really caught my eyes also at San Antonio Breast. Now, this trial found a 24% reduction in the risk of disease progression or death when tucatinib, that's our oral HER2 inhibitor, tucatinib was added to trastuzumab emtansine, which we commonly call TDM1. Now, this was in patients that were pre-treated as well metastatic breast cancer. Patients had a median of 1 prior line of therapy, although the trial did exclude patients that had received prior trastuzumab deruxtecan. And that's really impactful because as our paradigm and sequencing of cancer treatments has changed and evolved in HER2 positive metastatic breast cancer, trastuzumab deruxtecan has been a standard of care now, second line. So we're saying really now, how does this data apply if patients were excluded that had now our current second line standard of care trastuzumab deruxtecan? So it makes us scratch our head a little bit more, and that's just how oncology goes, right? The data changes so rapidly. Now, another thing with this HER2 CLIMB-02 trial was that it included about 44% of patients that had active brain metastases. And we know that tucatinib-based regimens from the original HER2 CLIMB trial, where tucatinib was added to capecitabine and trastuzumab, has significant benefit in patients with brain metastases, and even a benefit across the board in patients that are pre-treated HER2-positive metastatic breast cancer, with a 5.5-month survival benefit. Now, that survival benefit is with adding tucatinib to capecitabine and trastuzumab. Now, when we look at this regimen that was just presented, HER2 CLIMB-02, we only have data with a progression-free survival benefit with adding tucatinib to trastuzumab emtansine, TDM1. We don't know just yet if this addition improves survival. So this is really giving us a lot of questions about how are we going to sequence therapy in later line HER2 positive metastatic breast cancer? Are people going to select one tucatinib regimen over another tucatinib regimen, or even try to use both of them? So it's really unknown. This is not currently FDA approved for tucatinib plus trastuzumab emtansine. I'm keeping an eye on NCCN because you know they're going to change at the drop of the dime any day now and possibly incorporate this. And we're also waiting for the full text publication of the trial because that can help us extend insurance coverage once that is available.
Yeah, I was going to say with two tucatinib based regimens, it will be interesting to see, what is going to happen if it does become available.
You got it. And on the managed care side, that's where your payers really need to pay attention to this, because most payers may have a coverage limitation in their tucatinib drug coverage policy because we do not have any data currently on whether tucatinib is going to be efficacious after the disease has progressed, has grown already on tucatinib-based therapy. So here, your payers may have a coverage limitation because there is a lack of evidence-based medicine to support using tucatinib for a second trial after disease has progressed on tucatinib-based therapy. So that's why I think it's going to be where your providers may need to consider one tucatinib regimen over another, because a second regimen or using it later in sequence with disease progression on tucatinib is unlikely to be covered from a managed care perspective.
A lot of really exciting data coming out, but sounds like we'll need to wait a little bit longer to see what the guidelines are saying and what the more mature data as that comes out, what that looks like. So, one last question, Laura. So out of the three studies that we kind of discussed, what do you think is going to be the biggest impact?
Out of the three studies, the biggest impact, in my opinion, is going to be the INAVO120 trial, because once investigational inavolisib becomes FDA approved, I think that's going to change the game, because then we will have a 3-drug regimen for first-line recurrent hormone receptor positive, PIK3CA mutated, HER2 negative metastatic breast cancer. I think that one had the largest progression-free survival benefit out of the trials that I saw in the metastatic breast cancer setting. And that was one that had a lot of enthusiasm around a regimen that can perhaps move the needle to improve outcomes. We even saw over 1.5 years of a duration of response for those that responded to inavolisib. That is a long time to respond in the first-line setting, and that gives our patients a lot of promise.
And I'm really excited to see what comes out and what the guidance says. So, Laura, I want to thank you again. I've learned so much just talking to you about these studies. I'm sure we will see you again as the data continues to come out. And, I'm sure I'll see you at the next meeting because you are everywhere.
My pleasure. I always love sharing insights, especially if it's with breast cancer therapies. My pleasure.